So how about if I stand here? Can you hear me?
Yes.
Okay, good.
Tonight we have the pleasure of having Dr. David Rose, who is the chairman of the Department of Internal Medicine at New York Hospital Queens. People have asked me before whether the Department of Internal Medicine is, surgery and what it is really. It's the most important and largest department in any hospital because there are doctors in it. How many units? 400, 500?
800.
800 people in the Department of Medicine that he's responsible for. Responsible for teaching residents, teaching medical students from Cornell University, and making up budgets and all that kind of stuff. And he has to be aware of all the things that are going on in this world in terms of what's happening to medicine. I'm going to introduce him, but before we start, again, please hold your questions for later. I'll give you index cards and a pen to write them on. It works out better that way instead of raising your hands and interrupting. Dr. Rose.
Well, thank you so much.
Telephone?
Thank you, ladies and gentlemen. I apologize for turning my back to you. Is that okay? Can you see me and can you see the screen?
No.
Am I in your way?
No, it's actually good.
Okay, all right. So thank you. I want to thank Dr. Bright for inviting me, and Dr. Bright and Dr. Welschinger for organizing this series. And I want to thank you for coming out tonight. I think this is really wonderful. I was very impressed with the series that I saw that Dr. Bright had organized. And I'm honored to be here tonight. So thank you. I'm giving this lecture. This is the first time I've ever given this lecture. And I pieced it together actually from some other lectures that I gave to our residents and medical students. I entitled this "The Future of Healthcare."
Can
But I
you
have
give
to warn
just
you.
a telephone number we can reach in case somebody's...
I'll give you my contact information. Actually, let me give it to you right now. All right.
Oh, somebody asked me about your sister, if they're ill, so...
So, how do I advance? You'll do it?
He said you'll tell him.
Oh, okay.
Well, thank you.
All right. So, okay, so advance it to the next slide. So here's my disclosure. I can't really read the future any better than this man can. But I have been a student of healthcare organization and healthcare policy for quite some time. I've practiced in a variety of settings in healthcare. I worked in a private office for part of my career. I was a dean in a medical school for part of my career. I ran hospital programs for part of my career. And I've served on national health policy panels and have worked for national organizations to try to figure out the best way to advance healthcare.
Can I ask you what insurance carrier do you...
So I'll talk to you in a few minutes about insurance because I'm actually going to get to it. Okay? We'll talk about insurance because that's going to be part of it. But let me just say that what I'm going to be talking about is actually where we are in healthcare today and the problems with healthcare that are really forces for change in healthcare. Healthcare has been changing much more dramatically over the past 5 or 10 years than ever in the past 4 decades. And the acceleration of healthcare changes is really increasing. And I think that we're about to see enormous changes in healthcare over the next several years. And so I'm going to be talking about some of those changes. I'm going to try to explain Obamacare in about 10 or 15 minutes. It'll be quite complex because, as you all know, it's one of the most complex laws that was ever passed. It was passed in 2010. And I'm going to try to I synthesized it into 7 points that I'll try to explain to you. And then I'm going to give you some of my predictions about what I think is going to be happening to healthcare over the next couple of years. And then I'd be interested in having a discussion with you, if we have any time at the end, to talk about what you think is going to be happening to healthcare. So you can't begin to talk about healthcare, that where we are today, without focusing on healthcare costs. This is an article that was in the newspaper, the New York Times, about a week ago. I think it was on a Sunday or a Saturday. It was a really interesting article. $2.7 trillion medical bill. Colonoscopies explain why the U.S. leads the world in health expenditures. Actually, it wasn't just about colonoscopies. It was about lots of things. And it showed that colonoscopies in New York City range in costs from about $800 to about $9,000. New York City is one of the most expensive places to get a colonoscopy, but the range is enormous, probably 10 times from the cheapest to the most expensive. And then there was an article in Time magazine, it was on the cover of Time magazine by Stephen Brill, and it was called Bitter Pill, Why Medical Bills Are Killing Us. So I think more and more we're starting to focus on the costs of medical care. And it's really starting to, we never really focused, if you think back over your life, we didn't really focus on medical costs in past decades, but we have over the last decade and a half for reasons that I'll explain, and I think will sound familiar to you, and mostly it's because it's gotten so enormously expensive. So this is a little bit of a complex slide, but it shows from around 13 years ago and around 5 years ago, the proportion of states in which, the proportion of people in states that were uninsured. And white is good, that is a low proportion of people that are uninsured. You can see here, white means less than 14% uninsured in a state. And so you can see the Kansas is 14%. And dark is bad, that is a very high proportion of uninsured. And you can see the growth of the uninsured population in just about a 6-year period. Some of the southern states, and even in California, large proportions of people are uninsured. And actually, Texas today has about 33% of the people in Texas do not have insurance. And this is disastrous, and actually, it's disastrous for people to not have insurance. And this slide, also a little bit complex, but I want to go through it with you. This slide explains how bad it is for an individual to not have insurance. And there was a study that was performed a couple of years ago in which they looked at people with cancer, cancer of the colon, lung cancer, melanoma, and breast cancer, to see when they first came to the doctor. And people who were uninsured were much more likely to come to the doctor with late-stage undiagnosed cancer than people who are insured. People who have insurance go to the doctor early on when they have an illness. People who don't have insurance wait a long time, and therefore their cancer is more spread, and they're twice as likely to have late-stage cancer, colon cancer, than people who have insurance. 3 times as likely to have late-stage breast cancer than people who have insurance. And people with health insurance have their problems as well. So, as you know, about 3/4 of the people in the United States have health insurance, and about 1/4 of the people in the United States do not have health insurance. Most people in the United States with health insurance have either Medicare or Medicaid, public insurances, or private insurance. It's about 50% of the people in the United States have private insurance, usually through their employer, and about 1/4 of the people have Medicare or Medicaid. People with private insurance who have health insurance are really starting to suffer as well. And this has really been a problem that's really hit us, Americans, in the last decade. One of the problems is the costs are rising enormously, and the insurance companies have been discriminating against people with pre-existing conditions. As you know, if you have a pre-existing condition, it's very difficult to get health insurance. And if you ever lose your insurance, it's very difficult to get it back again because the insurance companies were, before the health care law that was passed 2 years ago, allowed to discriminate. And as we all know, out-of-pocket costs are growing and growing and growing to the point now where it's literally thousands of dollars. And I'm going to show you a slide of calculations of out-of-pocket costs for the average American. Many health insurance plans do not pay for preventive care. They don't pay for things like colonoscopies, mammographies, and other preventive care. Many insurance plans were allowed to drop you as soon as you got sick, so they didn't have to pay for people with severe diseases. Most states in the United States did not have laws against doing that, so it was perfectly legal for a private health plan to drop you as soon as you became very sick. Most private health plans had annual caps for payment for how much they would pay for each year, or lifetime caps on coverage. Many health plans didn't have guaranteed renewal. And people with health insurance, more and more people who have health insurance are feeling insecure. Just a couple of years ago, 48% of people lost their health insurance and were without health insurance for 1 month. 48% of people who had health insurance lost it for more than 1 month over a 4-year period. And over that same it's a 9-year period. Over that same 9-year period, 36% of people who had health insurance lost their private insurance for more than a year. So it's very common for people with insurance to actually lose their plans. And as you know, if you have a pre-existing condition, it's almost impossible to get it back again. And one of the most severe problems that we have in America is that 62% of all personal bankruptcies in the United States were caused by health problems. And most of so health problems adding to costs are a big factor in personal bankruptcies. And most people who have personal bankruptcies are actually insured. And the problem with that is that they lose their insurance, or the co-pays are so enormous that they're not actually able to pay, and people declare personal bankruptcy. One of the biggest problems that we have in the United States is that healthcare costs are rising much more rapidly than inflation and the rate of wages. So every year, healthcare costs are a larger and larger proportion of all of our earnings, and they're actually taking money out of our pockets, and I'll explain that on this slide. So this is a little bit of a complex slide, and I want to go through it with you. This was published in the New England Journal of Medicine, probably the preeminent medical journal that all doctors read. This was published a couple of years ago, but it's about 2006 data. So in 2006, the average income of Americans was $66,000. The median income of Americans was $48,000. What that means is that if you average all of the income in the United States and you divide it by the number of people, it comes to 66,000. But if you line them all up and you look at their incomes, they're right in the middle. The people right in the middle, 50% of the people, that's $48,000.
What size family?
The 80th percentile for income in the United States was $97,000. And in addition to the $48,000 that the average American made, the employer contributed $6,000 to an employer insurance plan. Now, insurance plans, if you're an employee, your employer pays about 2/3 of the cost of your insurance plan. So I'm an employee of New York Hospital Queens, and my employer, New York Hospital Queens, pays, I have a family plan because I have a wife and a son on the plan. My employer pays about 2/3 of the cost of that plan, and I pay about 1/3 of the cost of that plan. In 2006, the average cost of an employer-based insurance plan was about $12,000, and the employer contributed $6,000. The employee contributed about $3,000 to the cost of that plan. But the average American was also paying about $1,900 for out-of-pocket costs as well. And the average American was actually contributing to Medicare, Social Security, and Medicare an additional $5,000. And so the average American with an income of $48,000 was paying a total of $16,000 for medical care. $16,000 for medical care. This is the average American is paying $16,000 for medical care with a $48,000 take-home pay. And as you can see, the amount of money that the employer was paying for the employer's part of the insurance plan is $6,000. That $6,000 is foregone wages. That is, that's $6,000 that we wouldn't ordinarily pay, that we could have paid as wages. And so as insurance grows more and more expensive, wages are going down or are being suppressed. We cannot continue, and these wages are really starting to affect our economy. Just a few years ago, the average plan was $12,000. About 6 years from now, the average plan will be $24,000. So that's really starting to affect wages in the United States. I think I'm going to skip over this slide. This is just too much for me. I want to talk about now quality of care and value. So we talked a little bit about costs, but I think that there are problems with quality of care as well. There was an international study that was conducted that was looking at quality of care in 7 different countries: Australia, Canada, Germany, Netherlands, New Zealand, the United Kingdom, Great Britain, and the United States. And they ranked the quality of care and a bunch of other variables in care among all of these countries. And they tried to rank the countries from 1 to 7 based on surveys of patients in those 7 countries. And dark is best. Dark is like number 1 for quality of care was Netherlands. Effective care was New Zealand, and timeliness of care is the Netherlands. Long, healthy, productive lives is Australia. And you can see that the United States was either the worst of the 7, was either number 7 or number 6. Only one or 2 categories did we reach number 4. So we're actually starting to fall behind other industrialized countries in quality of care. And there's another study that was performed on just medical mistakes, comparing medical mistakes in 8 industrialized countries. Reading across the top from left to right: Australia, Canada, France, Germany, Netherlands, New Zealand, the United Kingdom, that's Great Britain, and the United States. And among, on average, 14% of people in the United States had wrong medication or wrong dose of their medicines, whereas only 9% in the United Kingdom and 7% in Germany. A medical mistake in treatment: 16% of Americans had reported a medical mistake. These were studies of people with chronic diseases like diabetes or high blood pressure. Incorrect diagnostic tests: 7% of Americans had an incorrect diagnostic test in a year. Delays in abnormal test results: 16% of Americans had delays in abnormal test results. I don't know if you can read the bottom, but it's any mistake of these 4. In Australia, 29% had any mistake. In Canada, 29% had any mistake. In France, 18%. Germany, 19%. In the Netherlands, 17%. New Zealand, 25%. The United Kingdom, 20%. In the United States, in that study, 34% of people had one of these 4 or more mistakes. Another problem that we're starting to see, and I think you might recognize this, it's the overcrowded emergency room. I don't know if you've been in an emergency room recently. My son and daughter-in-law and grandchildren were visiting us a couple of months ago, and my son got a really severe migraine. And I told Mel that we live in Brooklyn, so we went to the emergency room at a Methodist hospital. which has a pretty good reputation. It's part of our healthcare system. It was a horrible experience. It was really not a good experience for my son. It looked like this, and we felt really terrible. He didn't really feel well until we got home. There's another problem that we're having in the United States, and Mel may recognize this. It's what we call the primary care workforce crisis. Fewer and fewer young medical students and residents are choosing careers in primary care, and more of them are choosing careers in radiology and anesthesiology and other specialties. So in 1998, you can see the gray column is the proportion of people of third-year residents choosing careers in primary care, and it comes to about 55%, and careers in specialties about 40%. And you can see that the people every year from 98 to 99 to 2000, fewer and fewer residents are choosing careers in primary care. It keeps going down. And the white columns are people choosing careers in specialties. It keeps going up from 1998 through 2007. More and more people are choosing careers in specialties. There's a problem with that. If you could give me the next slide. The problem is that it's harder and harder to have a career in primary care. Dr. Bright will explain to you that that primary care physicians are working harder. There are fewer and fewer doctors, and therefore they're seeing more and more patients with shorter and shorter visits. You might have had the experience of going to the doctor and spending only 10 or 15 minutes with the doctor. The average time spent in a primary care doctor's office now is down to about 12 minutes. I think you can all see that no patient likes to go in and out in just 12 minutes, and doctors don't like it as well. And doctors feel like they're practicing on a hamster wheel. We talk about this hamster wheel medicine where you're running faster and faster and faster and faster and faster. And as Dr. Bright will tell you, it's harder to practice medicine today than it was to practice medicine 35 years ago. We have more and more guidelines. There are more things that we need to do for our patients. We have more vaccinations that we have to do. There's more preventive care that we need to be providing. And it's more and more complex. The average patient in 1965 took 1 or 2 medicines. Today, the average patient probably takes 5 or 6 medicines. It's not uncommon. In Dr. Bright's office, I'd be willing
There's
to
no
bet
problem interaction of their medicines.
And when you're taking 5 or 6 medicines, or I'd be willing to bet that Dr. Bright has some patients with 10 medicines, there are lots of interactions with those medicines. And it's very hard for the doctor to make sure that it's safe for patients, and try to do that in 12 minutes. Next slide, please. I am going to, well, I'm not going to skip over this. I'm going to try to explain something to you. This is the relationship between primary care and healthcare costs. In states, each one of these dots down here is a state, and they ranked every state by the proportion of general practitioners in that state. So you can see that Vermont has a high proportion of general practitioners. And I don't know if you can see this dot over here, that's Nevada. They have a lower proportion of general practitioners. And on this axis, they ranked the states by how expensive the average Medicare patient, how much money the average Medicare patient spent. So you can see in Nevada they spent about $6,500, in Louisiana about $8,000, and in Vermont about $5,000. And in the box here is New York. In New York, the average person, and this was in 2000, the average Medicare patient spent about $7,000, and New York has about 2 to 3 general practitioners per 10,000. So what we see is that as the proportion of general practitioners goes down, healthcare spending goes down. And up here, it's the same costs on this axis, but it's the proportion of specialists. And you can see that as the proportion of specialists goes up, healthcare spending goes up. So the primary care doctors keep spending down, specialists have spending go up. And I think that Dr. Bright would recognize this as well. Can I see the next slide, please? Okay, now this is the same study in which they looked at quality of care, and they compared quality of care to the proportion of general practitioners. So you can see here the same, Vermont has, many general practitioners, and over here they ranked all of the states, each one of these dots is a state, by quality of care, from number 1 to number 51. They included the District of Columbia in this. And you can see that as the proportion of general practitioners increases in a state, quality of care goes up. As the proportion of specialists goes up, quality of care goes down. And so losing primary care doctors is a problem for our nation because because primary care physicians, like Dr. Bright, keep costs down and quality up. Next slide, please.
What's the average cost?
And so it's about, in our state, the average person probably spends, with Medicare, about $8,000 per year. And so that means that there's some people that spend $20,000 and some people that spend $0. And so in summary, the problems that we're facing are many people have no health insurance. For people with health insurance, costs are rising rapidly, and there are unfair policies and coverage uncertainties. The rising cost of Medicare and Medicaid, and I didn't really talk about the rising cost of Medicare, but as you know, Medicare is a public insurance, and it's becoming a bigger and bigger source of financial costs for our nation, and it's become a real problem for our nation. We're spending nearly as much in Medicare as we spend for the US Navy. The rising cost of Medicare and Medicaid is unsustainable for the federal government and state governments, and fee-for-service payment raises costs. One of the reasons why we have these costs is because of the fee-for-service system. I'm going to talk about it in a few minutes. And we're falling behind in quality of care. We're behind other wealthy nations in quality of care. And uncoordinated care leads to overtreatment, undertreatment, and inappropriate treatment. How did this happen to us? How did this happen to us? The next slide. So, it happened to us because this is our health system. It's a mess. It's a mess. There is no system. It all seemed to work. Nobody did this on purpose. We're all doing our best. Honestly, we're doing our best. Look at this young man over here. I mean, each of us has our own little piece of work, and we're all doing the best that we can, but because it's uncoordinated, it's really gotten out of control. And it's going to be very, very, very difficult for us to get this back in control. So one of the things that we talked about, if you recall back in 2009 and 2010 when we were debating the healthcare reform, we talked about bending the cost curve. So from your perspective, costs over time are going up and up and up and up like this. And bending the curve is trying to keep it, actually have it go back down again. How do we actually do that? So when we were talking about healthcare reform in 2009 and 2010, incidentally, I don't want to talk about politics because I don't know any more about politics than the rest of you do. I just want to talk about what we were trying to do on both the Republicans and the Democrats, what we were trying to do and what we ended up doing. So what we were trying to do was to ensure everyone to reduce healthcare costs for both people with public insurance like Medicare and Medicaid and people with private insurance, to prevent the abusive health industry practices of cutting people off and refusing to give people insurance, and to improve quality of care and patient satisfaction. When I talk about quality, I'm also talking about patient satisfaction. We want to feel as though we're getting what we need done when we go to the doctor or when we go to the hospital. What we got was Obamacare. And it's a little bit of this and a little bit of that, and I'm going to try to explain to you in about 10 minutes Obamacare. This must be the most difficult lecture I've ever given in my entire life. Try to explain a 2,000-page law in 10 minutes. Actually, I want to do it in about 8 minutes. Let's see if I can. So what Obamacare, it's also called the PPACA, the Patient Protection and Accountable Care Act of 2010, or the ACA, the Accountable Care Act, or I'm sorry, the Affordable Care Act. I heard someone saying it. The Affordable Care Act. But it's come to be called Obamacare, and I think we're all just going to continue calling it Obamacare. It has four main purposes. One is to provide health insurance for the uninsured. The other is to bend the cost curve of Medicare. And the third is to bend the cost curve of private insurance plans. Remember, half the people in the country have private insurance. And then the fourth is to improve the quality of care and value. So value is quality for the amount of money that we spend. Next slide, please. And so some of the principles of Obamacare, what we ended up getting in this complex bill, or law now, so the principles are that it keeps in place today's job-based private insurance system and Medicare. So if you have your employer-based insurance, or if you have Medicare, there are very few changes. I'll mention the changes, but there aren't that many. It's really about the people that don't, it's about the 1/4 of the people in the country that don't have insurance. It provides a new way to obtain insurance for people who are locked out of the marketplace for insurance because of pre-existing conditions or the inability to afford insurance. And for people with insurance, it does offer additional benefits. And so it actually goes into, it affects people with, my insurance plan is Aetna. I buy it through my employer. And it actually affects Aetna's employer-based plan that my family buys. So I'm going to tell you 7 things that you should know about Obamacare. First, I'm going to tell you about changes that took place in the first couple of years, between 2010 when it went into effect. It went into effect in the fall of 2010 through today. And the second thing I'm going to tell you is what you're going to see in 2014. That's probably the biggest year of changes in Obamacare. The third is what you've heard about the individual mandate, and I'll explain to you what that the individual mandate is. The fourth is you've heard about these health exchanges or online marketplaces. I'm going to try to explain to you what that is. The fifth is there are aspects of Obamacare that help people who can't buy insurance. It actually gives them money to buy insurance. And I'm going to explain to you how that works. There are some parts of the law that affect employers, and I'm going to tell you about what the parts of the law are that affect employers. And then finally, I'm going to talk to you about Medicaid expansion. So the first thing is, what's happened in the first 2.5 years of Obamacare? What have we seen already? So first and foremost, it outlawed practices that left people without health insurance when they needed it most. So it stopped insurance companies from canceling policies when they got sick. This is probably one of the most evil things that insurance companies did. I couldn't believe that it was legal in about 40 states for insurance companies to just drop you. If you got cancer or a severe disease like multiple sclerosis that ended up being very expensive, it was completely legal for insurance companies to just drop you. It's no longer legal for that to happen. That's something that the insurance companies call rescission, and it's no longer possible. The second is, if insurance companies give you a hard time, there's now a rule that they have to allow you to appeal and get back to you within, I think it's 90 days. It used to be that they would take years to appeal some financial decisions. Incidentally, I'm not an expert on Obamacare, so I'll tell you a really good thing to read if you're at all interested in this at the end. The third is that it bans lifetime limits on coverage. So it was quite legal for insurance companies to say we're gonna actually limit how much we're going to pay for your medical care for your lifetime. And some of the limits were $1 million, some were $2 million. For some people needing bone marrow transplants, people with diseases that require the new biological drugs, some of the drugs cost $10,000 a year, they were actually hitting those lifetime limits. There are many children with orphan diseases, and it was very common for people to be hitting their lifetime limits at the age of 7 or 8. And then the insurance company is saying, we're not going to pay anything more. That's no longer allowed. And then it actually limits, it actually gets rid of annual limits. This year, it requires insurance companies to pay up to $2 million per year. And starting in 2014, that is next year, there are no annual limits allowed. Next slide, please.
How about by catastrophic insurance?
Catastrophic insurance. I'll talk about that in just a minute. I'm going to speed up, I think, because I know that some people are going to be leaving very soon. I want to just talk about a couple of other things. What we currently have is it requires insurance companies to pay for preventive care, like checkups, immunizations, and cancer. It requires insurance companies to give rebates if they're spending too much money on administration and paying stockholders. Last year, $1.1 billion was distributed to about 2.7 million Americans because of those rebates. And it requires all insurance companies to write their plans clearly so that you can understand the law. It expanded coverage for young adults. It chips away at pre-existing conditions, and children under 19 with pre-existing conditions cannot be denied coverage. But the insurance companies are allowed to raise prices in 2013. In 2014, they have to stop doing that. There are a few changes to Medicare. One of the changes to Medicare is, as you know, that there's something called the donut hole. If you have deductible, the donut hole applies to your drug plan, the Medicare Part D drug plan. So it pays for your drugs up to a certain amount of money, and then it actually stops paying for it. So if you have more than $2,900 in costs, you have to pay for it out of pocket until it gets up to about $5,000. Then it will pay for those costs again. So there's this thing called the donut hole. This donut hole is getting smaller and smaller and smaller under Obamacare, and it's going to disappear by 2020. That is, it will pay for more drugs from Medicare Part D.
The drugs effective. I heard a lot of people die from those drugs.
A lot of what?
There are casualties from drugs.
Side effects.
Side effect or other casualties.
We'll talk about that in just a couple of minutes. So this is what's going to happen in 2014. So in 2014, the rest of the slides are actually about 2014. The goal is, and this is going to be the biggest effect of Obamacare, to make affordable health care available for all Americans, regardless of their medical history or the ability to pay. Most Americans are going to be required to have health insurance, and if they don't have health insurance, they're going to have to pay a penalty, $95 per year, or 1% of their income. But that, over the next couple of years, will actually go up. And then in 2014, we're going to have these online marketplaces or exchanges, which I'm going to talk about in a couple of minutes. All insurance plans have to offer a basic minimum set of benefits. Every insurance plan, and today there's no requirement that insurance plans offer all of these things. By 2014, every single insurance plan has to give you emergency services, hospitalizations, lab services, maternity care, mental health and substance abuse treatment, office-based care, or outpatient care or ambulatory care, pediatric care, prescription drugs, preventive care, rehabilitation services, and vision and dental care for children. That's just a minimum. The plans are allowed to offer more, but every single plan must offer this. And in order to pay for giving these insurance plans to people that don't currently have insurance, there are going to be 2 new taxes that start this year, actually, that are going to help fund for Medicare. They only apply to wealthy people. They don't apply to individuals who make less than $200,000 a year, or they apply only to couples that make more than $250,000 a year. There's an extra payroll tax of 0.9%. That's only for wealthy people. And then there's an unearned income tax of 3.8%. And that's a tax on investments, interest, or dividends. So how will the mandate affect you? So first, I think you know that, that the government was sued, and the Supreme Court made a judgment this past year that said that the individual mandate is constitutional, and that you can make people buy insurance, just like states make people buy car insurance. The federal government makes people buy health insurance. It only affects about 7.3 million Americans. It comes to about 2% of the population. And the only people that are exempt from this rule are people for whom the cost of the insurance is greater than 8% of their household income. And it's basically people that don't have insurance, don't qualify for Medicaid, don't qualify for Medicare. And as you know, Medicare is for everybody over the age of 65 and younger people with disabilities. Medicaid is federal dollars that go to the state, and it's for people who are low income. Next slide, please. And then the other thing that you're going to be hearing about are the exchanges. The exchanges are basically computer screens. You can log on from home, and the exchanges are going to be run by each state. So New York State is going to have the New York State Health Exchange. There are some states that don't want to do it, and so the federal government is going to run it for those states. So like Texas refuses to do it, so Texans who log on will see a Texas state exchange, but it's actually run by the federal government. And what it does is it shows you all of the health plans that are available to you, and it makes the comparisons, what we call apple-to-apple comparisons. So you'll be able to see the cost of the plans and the benefits of the plans in easily readable language. As you know, if you've ever looked at the paperwork for health insurance, it's impossible to understand. I consider myself to be well-educated and a student of health policy. I read up on this stuff all of the time, and I can't understand the paperwork for my own insurance plan. It's just absolutely horrible. I don't know if you've ever tried to decipher it. It's impossible. It's completely impossible. I get all the paperwork for my mother's insurance. My mother lives in a nursing home in Philadelphia. I get all the paperwork, and I can't understand what they're saying. And my poor mom, she's 95, she couldn't possibly understand this stuff. And so what the exchanges do is it's required by law to reduce it to very simple language and very easy comparisons. And one of the things that you can do is you can sit down and in one session in front of your computer, you ought to be able to compare all of the insurance plans and sign up for them and make and get a plan, and then see if you're eligible for tax rebates or for help from the federal government to actually pay for the plans. So in one setting, you ought to be able to, in an hour, or maybe it might take as long as 90 minutes, get your sign up for your plan and register for financial help to actually purchase the plan. Next
Which is
slide.
the best rated plan? And do you advise people to take also for home care, you know?
Can you do that later?
I'll talk about that
Okay,
as soon at the end when we talk about questions and answers. And so there are many ways that the federal government is helping to pay for these plans. There's discounts in the form of tax credits, subsidies for out-of-pocket expenses, Medicaid for those with limited incomes, and options for young adults, even more things that are available for young adults. And there's actually, the screen that you're going to have is going to have an online calculator. Right now, if you want to try to figure out what your financial situation is, you can go to the Kaiser Family Foundation. Most of these slides, incidentally, are from the Kaiser Family Foundation. It's a terrific website, and it will explain Obamacare to you. But starting in October, the exchanges are going to be available to all Americans, a site in each of the 50 states, and you'll be able to go onto the website. It will tell you what the insurance plans are that are available to you. This is only for people that don't have insurance. and it will tell you how you can get help paying for these plans. I'm going to actually skip over this. Obamacare does not require businesses to purchase insurance. So there's no employer mandate. There's only an individual mandate to buy insurance, but there's no requirement that businesses must buy insurance. But there are many options for businesses to help. There are actually tax rebates for small businesses. And a small business has fewer than 50 employees to actually help the business buy insurance for their employees. And they can actually go onto the website. There's our New York State plan is called SHOP. Our exchange is going to be called SHOP. The New York Health Benefits Exchange is Small Business Health Options Program. So it's not our exchange. This is a program for businesses, and it helps businesses figure out how they can purchase insurance for their employees. Next slide, please.
Should businesses be penalized?
No, businesses will not be penalized. Well, actually, there's one penalty. Businesses with more than 50, no, I'm not a lawyer.
They
But,
can be
yeah,
penalized.
so businesses with more than 50 employees
Yeah.
that either refuse, go back one slide. I might have put it on the slide. So if they offer insurance that's too expensive, they will be penalized. In other words, if they offer only Cadillac plans, then there are actually penalties. But it only applies to 4% of businesses.
How about if people, how about people end up going on using the Obamacare and they work for a company?
Yeah, so if you work for a company, and if I see that my Aetna insurance, my part of the insurance is too expensive, I'm allowed to go on the exchange. It will open up in October, look and see if there's a cheaper plan, and I'm allowed to buy through that cheaper plan.
Just a question. There was a thing with Walmart a few years ago.
Walmart
Walmart was telling its employees to get Medicaid and not giving their employees, so Walmart would have to pay that penalty?
I don't know.
No, they would tell people the insurance costs all this money,
Yeah.
Walmart gets paid cheap.
I think there are penalties for large businesses that don't offer any insurance, but I'm not sure about that. As I said, I'm not an expert on this. I'm trying to reduce this to just a few minutes.
Which is the best rated plan?
Medicaid, so as you know, Medicaid is now available for 60 million low-income Americans. It's going to expand. It's going to be federal dollars to states, but about half the governors have refused to do it. So there are going to be about half the states will not expand their Medicaid. Half the states will expand their Medicaid. And it's all federal dollars. It's not costing the states any money at all. So New York State will expand. And so New York State will very soon have very few uninsured people. So now I'm basically done with Obamacare. I'm going to tell you what I think are going to be key trends in healthcare over the next couple of years. And then I'd be interested in Dr. Bright adding to this, because I think you've probably been thinking about this as well. So the first is doctor-nurse, what I call doctor-nurse. More and more nurse practitioners, physician assistants, and others getting doctorates and practicing, not practicing medicine, but practicing primary care. These are called basically primary care providers. And so I found this on the web just today. Dr. Lawrence, he's the 2012 Georgia Nurse Practitioner of the Year. He's called Doctor. And this is a nurse practitioner who's also called Doctor. The next slide. I found this on the internet recently. Making room for Doctor Nurse. This was an article in the Wall Street Journal. And in the red box it says, more than 200 nursing schools have established or plan to launch Doctorate of Nursing Practice programs to equip graduates with skills the schools say are equivalent to primary care physicians. I'm not so sure about this, but that's what's happening. Next slide, please. And this one from the University of Tennessee. The Doctor of Nursing Practice curriculum is web-based, web-mediated. So you can get a doctorate on the web and call yourself a doctor and open up an office. This is happening in America right now. And then they're going to be competing with Dr. Bright, who spent, all those years of college and medical school and training.
And got into medical school.
And got into medical school, that's it, because he is brilliant, that's exactly right. Here's another trend I think is happening, the rise of Urgy centers and minute clinics. So I told you the story about my son and daughter-in-law and their kids, and my son had a migraine attack and we went to Methodist Hospital. They come back and visit us about a month and a half ago, and the baby, a toddler, had an ear infection. And his wife said, I'm not going back to the emergency room. So she's a modern person. She Googles, nearest Urgy center to where we live. Within walking distance, there was an Urgy center. And we went in, and it was a spectacular experience. I have to say, it was a spectacular experience. So these are people, my son and daughter-in-law live in South Carolina. Their pediatrician, is hours away. We were able to walk into a minute clinic, avoiding the emergency room, and go to an Urgy center and get the kid taken care of just like that. And it was very satisfying, I have to tell you.
More and more are coming.
What's that?
You see them on the streets.
More and more and more.
Like First
More and
Med?
more. I don't know if it's good.
Yeah.
First Met,
I'm
They're not
I'm
open at night.
I'm not.
Yeah, they are. They're open till 9.
Some of
Look
them.
When you get sick at midnight.
Some of them. The one that I went
Back to the
to.
emergency room.
The one that I went to actually didn't open until 7 in the morning on a Saturday, but they were open at 7 in the morning. And you can see this. This looks like Walmart, right? Or Walgreens, or the CVS that we go to.
By the way,
And why is it? Why is it that this is happening? Well, they surveyed people, and they said the reason for choosing retail clinics, the clinic hours were more convenient, the location was more convenient, they didn't have to make an appointment, the cost was lower than another source. But here's the one that bothered me, and this I'll bet is going to bother Dr. Bright. These are 34% of these people said they didn't have a doctor. That's why they were going to the minute clinic. Next slide, please. And then they surveyed these minute clinics or these Urgy centers, and they care for people with chronic conditions like diabetes and high blood pressure and high cholesterol. These minute clinics are doing what we think of as people like Dr. Bright doing, taking care of people. Next slide, please. So I'm not so sure that this is a good trend, but I think that this is a trend in medicine. Here's another prediction of the future. Employed physicians. More and more physicians are going to be employed and working in larger and larger health systems. So when I came out of medical school about 30 years ago, actually about 35 years ago, 95% of doctors were self-employed. They worked in solo practices or small practices, 2 doctors, 3 doctors at the most. 15 years ago, only 75% of doctors were self-employed. So 35 years ago, 95% of doctors were self-employed, 5% worked for hospitals or worked for medical schools. Let me see the next slide. So you can't see the colors here, but the doctors in 2002 who were self-employed were 75% of doctors, and 25% were employed by hospitals. And this is in 2002. So over the years, doctors who are self-employed are fewer and fewer and fewer, and doctors employed by hospitals are more and more and more. And it's really starting to accelerate. More and more doctors, many of the doctors in our community, are looking to become employed by hospitals. Next slide, please. And this was an article by Pauline Chen, if you ever read her. She's a doctor who writes for the New York Times. And I mostly like the first sentence. I just thought it was a great sentence. It's a piece of art. Like wildebeests thundering across the Serengeti in search of greener pastures, doctors have been fleeing their private practices for hospital employment. Doctors fleeing their private practices for hospital employment. It's really, I actually find it disturbing, but it's a reality. Over the last decade, there has been nearly 75% increase in the number of doctors employed by hospitals. Nearly 3/4 of hospital leaders say they plan to increase that percentage over the next 3 years. Just today, I hired a doctor And last week I hired another doctor to be working in our community. Doctors, especially young doctors, want to be employed by hospitals. And today, so from over the last 13 years, the proportion of doctors that are self-employed has been going down about 2% per year. In 2012, it was down to 39% of doctors are self-employed. 61% are employed by hospitals. And it's actually accelerated. And we actually think that the number of employed doctors is going to drop even more over the next couple of years. Another trend, I think, in medicine is alternatives for fee-for-service. So we pay doctors by the service. We pay a cardiologist for the EKG, we pay a hospital for the hospitalization, we pay a hospital for the emergency room visit, we pay an orthopedist to set a bone, we pay a fee for each service. But there are new alternatives that are coming out. I'm not going to explain this slide, but this is called a payment for an episode of illness. So you can imagine an episode of illness would be something like knee operation. You would pay for all of the care of the orthopedist for the month before the operation. You would pay for the surgery. You pay the hospital for the surgery. You pay the radiologist for the X-rays, and you would pay the doctors for the care for the next 90 days. That's a bundled payment for an episode of illness. We've been doing that. The federal government has been doing that to some health systems for cardiac surgery, for coronary stents, stent placement, and for certain operations. Next slide, please. Here's one for total knee surgery. So imagine multiple insurance payments for a consultation, anesthesia, surgery, implants, physical therapy, the OR, the recovery room, and the hospital comes to $26,000. Now they pay a bundle payment to the doctors and the hospitals, one payment, and the goal is to coordinate and to try to keep the costs in check. Next slide, please.
Same cost, so I don't think it was the same cost exactly.
Well, on that slide.
Yeah.
It's not necessarily going to be the same cost. So one of the problems is that a knee operation, so go back to the very first slide that I showed. I don't know if you were here when I showed the first slide, for colonoscopy. So colonoscopy, so if you read the article in the Times, it was about a week ago about the cost of colonoscopy, the gastroenterologist charges, but also there might be an anesthesiologist who charges. And if you're getting the colonoscopy in a hospital, the hospital charges. Or if you're getting it in an ambulatory care center, the ambulatory care center charges. If you're getting it in a gastroenterologist's office, he charges for the colonoscopy and he'll do the sedation themselves. Right now, the insurance companies pay all of those fees. If there's a bundle payment, there's going to be one payment for all of those things, and there's going to be and so it's going to be up to the gastroenterologist and colleagues to try to keep the costs down. And then that way you'll be able to compare the costs.
Who should take
I'm not saying the bundle payments are going to be the solution. I just think that it's going to be happening, and I think that the payment is not going to be the same. It's going to be less.
Who should take, what age
Regarding
people should take
colonoscopies, if you have a choice, you do it in the doctor's office versus the hospital, the payments would be higher in the hospital. Now.
That's right.
Okay.
That
So
is-
what if somebody tells you you can't do it in a doctor's office? You go to another doctor
Correct.
to do it in his office.
That's right. That's exactly right.
What the person has to pay themselves to the insurance company.
Well, right now, because of insurance, the only thing you're really concerned about is the copay and the deductible, honestly. So you don't fully know what the cost of that colonoscopy is. That was one of the points of that article. I came in the next morning, and my secretary, Rita, Mel knows Rita, she said to me, "It's really weird. I didn't realize it. This is the only part of America where you find out the cost of something after you've had it done and after it's been paid. You know, when you buy a car, you pretty much know how much you're going to be paying up front, and in all other circumstances, you have an opportunity to bargain. It's not true in healthcare."
Who should take a colonoscopy?
Next slide, please. Next slide. One more slide. I'm gonna speed this up because I'm going much. As I told you, this is the first time I've given this lecture. So there's something that's happening that's called the patient-centered medical home. The patient-centered medical home was actually invented. It was originally invented by the pediatricians in the 1960s, and it was meant for children with disabilities. But over the years, it's kind of expanded. And then the primary care societies, the American College of Physicians, which is my professional society, the American Association of Family Physicians, and pediatricians got together about 3 years ago, and they invented something called the patient-centered medical home. Imagine Dr. Bright's office with a doctor taking care of patients with a nurse and a secretary. And then adding to that office one additional nurse who monitors when you have a test done, encourages you to get the test done, like if a mammogram is being performed. Makes sure that you get the test done. Makes sure that you know what the result is. Makes sure that Dr. Bright knows what the result is and gives you the result of the test. And the nurse also does something else, which is adds to Dr. Bright's nurse the ability to do something called self-management skills. So as you know, chronic diseases like diabetes and high blood pressure and high cholesterol really require a lot of understanding of the illness and a lot of understanding of the medicines. And the nurse spends a lot of time, much more time than a doctor can spend, trying to get patients to understand that. And so the patient-centered medical home has this care coordination, working with the doctor in the same office, and has it focused on the patient, but also has an additional payment to the doctor's office for that coordination of care and that self-management. And this is something that's actually happening. And we're developing patient-centered medical homes all around the city. Our hospital is developing patient-centered medical homes as well. Next slide, please. And then the last thing I want to talk to you about is something you're going to be hearing more about, accountable care organizations. So accountable care organizations, imagine 5,000 doctors, or 500 doctors, let's just imagine 500 doctors working with a hospital, or maybe working with 2 hospitals, taking care each doctor has, say, 2,000 patients. 500 doctors taking care of 2,000 patients. I don't know what 500 times 2,000 is, but it's a big number. 10,000? I don't know. But imagine this group of doctors is taking care of 100,000 patients. They receive payments for all of the care for these patients for the entire year. And there is no longer a fee for each service. So all of the doctors and the hospitals receive these payments, and then the goal is to try to maximize quality of care and patient satisfaction. And this organization, and it's basically an organization of doctors and hospitals, doles out the dollars based on patient satisfaction, based on your evaluation of the doctor's skills, as well as the amount of time the doctor spends with you. There are probably about 2,000 accountable care organizations in the United States today. It's basically a new concept, and the goal is to try to keep the costs down by preventing the most expensive part of healthcare, which is the unnecessary emergency room visits and unnecessary x-rays and unnecessary hospitalizations. I'm close to the end, and then I'm going to take your question. Next slide, please. So it's basically trying to organize the care with all of these patient-centered medical homes and hospitals so that your care manager is able to focus on you. And the goal is to try to optimize coordination of care. Next slide, please. I'm going to skip over that slide because I want to get to the questions. So these are some of what I think are the trends in healthcare. The doctor-nurse, urgent centers, employed physicians working in large health systems, alternatives to fee-for-service payment, patient-centered medical homes, and accountable care organizations. Next slide, please. So what do you think is going to be happening? So I'm basically done with my talk. I'd be interested in your comments and your questions. You had your hand up first, and then I'll take you. Go ahead.